Okay, so last time we finished up on corpus callosum. One thing, this is called a clicker session, and but I know from receiving several emails that some students are traveling. Some of you are observers of the course because you don't have student health clearance or something like that. And so I'm not going to use it for this one because I know not all of you can participate. But what we'll do in the future for clicker sessions is we'll use the time. I'll have interspersed questions throughout the lecture, and you'll just get full credit if you're here. It doesn't make up much of your grade, but it's just an encouragement, and hopefully the questions will be helpful as well. But I didn't want to too complicated for this one, so we'll bypass the clicker session. So one thing here, just to show you a dissection of the corpus callosum, massive, right? And kind of intuitively just makes sense, right? Our right and left hemispheres need to be communicating precisely with each other. And it's really hard for me not to tell you the interesting things that happen if you have a lesion of the corpus callosum, but we'll save that for later. Now, smaller commissural fibers include the anterior commissure. And anterior commissure, when we dissect the brain, it's the only pathway that looks like this. Depending on where you're standing, when your group does the brain dissection, it's either a frown or a smiley face. But what this pathway does is it interconnects the temporal lobes. Okay, and especially a part of the temporal lobe called the hippocampus or the hippocampal formations. Okay, so the anterior commissure is involved in that. Here's another look at the anterior commissure. So again, I realize you don't know anything what you're looking at here, but just this pathway is distinctive, the appearance. Okay, and a very, very small commissural pathway here is called the posterior commissure. Okay, and again, you're not oriented yet. I know you don't know any of the structures around here, but it's this tiny little pathway right at the end of the black arrowhead. That's all it is. Okay, but the posterior commissure is important later on when we talk about why is it when you shine a light into one eye that both pupils constrict. The posterior commissure is actually involved in that. That's really the only thing I'll tell you about the posterior commissure. So let's explain here in some wording. The posterior commissure is a border between the diencephalon and the midbrain. Well, the diencephalon is what we're going to talk about next. And this whole area of the brain right here is the diencephalon. Okay, this is the midbrain. Okay, so the posterior commissure is kind of this boundary right here, a landmark between the diencephalic structures and the midbrain. Okay, here's a closer up view, and you can see right there is the posterior commissure. So hopefully you'll all be able to see that Wednesday afternoon. Right, next, let's talk about the basal ganglia, which is a very interesting neuroanatomical area. Okay, basal ganglia, these are nuclei that are subcortical. Okay, so not all the neurons are out around the surface of the brain. Some are deeply buried within the brain, and the basal ganglia is a good example of that. Okay, and so the basal ganglia is very important for movement. If we want to say it concise as we can, it selects wanted patterns of movement and suppresses unwanted patterns of movement. So a patient that has anything going wrong with the basal ganglia has what's called a movement disorder. They have a tremor or something like that. Okay, so we have, I think, 3 hours on the basal ganglia. We'll go over Parkinson's disease and different types of tremor. Okay, but the dysfunction lies in the basal ganglia. Okay, so let's explain a little bit here the anatomy. Well, first, here's our friend, the internal capsule right here. And so the basal ganglia, some of these structures lie right around the internal capsule. So medial to the anterior limb, which is right here, is the caudate nucleus. And the caudate is always very distinctive, not just because it's medial to the anterior limb of the internal capsule, but it's also a nucleus that bulges into this space right here, which is the lateral ventricle of the brain. Okay, that's our lecture on Thursday. So this is the caudate nucleus. Okay, out lateral to the entire internal capsule, you have the putamen. Okay. And the caudate and the putamen work very closely together, such that we just give them one name, and we call it the striatum. So when you hear the term striatum, you want to think of both caudate and putamen. Now, if we cut a little deeper down into the brain, okay, we can still see the caudate. Here's the putamen. And you can see there's another nucleus. It looks a little different. It's like there's a little separation right here, and you have a more medial nucleus, okay? And this is called the globus pallidus. Okay, and because this has kind of a lens shape, the putamen and globus pallidus together, we have a name that encompasses both of these, and that is the lentiform nucleus, or the lens-like nucleus, the putamen and globus pallidus. Okay, so again, lentiform refers to the putamen and the globus pallidus. The striatum refers to the caudate and the putamen. And as a very big picture, later in the course, we will map out all the connections and what is going where. But the striatum, when the brain wants to talk to the basal ganglia, let's put it simplistically, to facilitate movement, it talks to the striatum. So the striatum, caudate and putamen, is the input nucleus, okay, from the cortex of the brain. And the basal ganglia processes all this information about movement. And as a big picture, when the basal ganglia wants to talk back to the cortex, it does so through the globus pallidus. So the globus pallidus is kind of the output of the basal ganglia. The striatum is the input, the basal ganglia. And this will actually be important because you can figure out all kinds of things just knowing what is doing what in the basal ganglia, whether the patient will have a rest tremor, whether they'll have an action tremor. It actually, learning it does pay off. So here is a different cut through the brain. It's what we call a coronal section like this. And I just show it because here we have a nucleus bulging into the lateral ventricle. So this has to be the caudate. And here's the putamen here. And the reason it's called the striatum is that there are these striations here that connect the caudate and the putamen. Now, there are many C-shaped structures in the brain. And in your, I think in the lab handout, I list them all. And the reason it's important to identify a C-shaped structure is that when we're cutting through the brain, or when we're looking at an MRI scan, it can be very confusing because if you cut through a C, you're going to see it here and then way back here, right? So you just have to be aware of that. So if the caudate is a C-shaped structure. So here's the head of the caudate, and it goes through a body and all the way back to a tail. So if you make a cut through the brain like this, you're going to see the caudate here, and you're going to see it way back here, okay? Because you just cut through a C, right? So the caudate has this shape, okay? And just an interesting thing here. I don't know if any of you recognize her from the old TV show Taxi, and she's been in some other things. Mary Lou Henner, I think her name is. But she has this very rare condition where she has an encyclopedic memory of every single day of her life. You could ask her, September 2, 1977, what were you doing? And she could tell you. It's only a handful of people in the world have this. But what was surprising when you do a special type of brain scan is these individuals have a very large caudate nucleus. And I'm telling you the caudate is important for movement. Well, obviously there must be some function also for memory because of the large caudate nucleus. So the brain's really complex and mysterious. So we'll try to make some general points, but then we find out something like this, which causes us to rethink what these areas of the brain are doing. So the internal capsule, again, is a really important landmark when we're trying to identify parts of the basal ganglia. And that should really be our first thing. When you make a cut, when you look at an MRI scan, find the internal capsule, anterior limb, genu, posterior limb. So notice medial to the anterior limb, you have the caudate. Lateral to the internal capsule, you have the putamen, and then the globus pallidus. Globus pallidus actually has two parts to it, which we'll talk about later, an external and an internal part. Okay, so I mentioned when the brain talks to the basal ganglia, it talks to the striatum. When the basal ganglia does its thing, talks back to the motor cortex of the brain, the output nucleus is the globus pallidus. Okay, that's as big of a picture as we can make it for now. Okay, here's that anterior commissure we just talked about. And so again, I know you're not oriented here, but there's a nucleus bulging into a lateral ventricle. So this must be the caudate. Okay, here's the internal capsule. And so out here we have the putamen and the globus pallidus. And I just show this because it was the nicest one I could find, showing you a clear separation between the putamen and the globus pallidus. So those are the telencephalic components of the basal ganglia: caudate, putamen, globus pallidus. But there are deeper parts to the basal ganglia, and so they're embryologically part of different areas. So for example, the substantia nigra is in the midbrain. Okay, if you go back to the first page of the handout, the midbrain embryologically is equivalent with the mesencephalon. Okay, so the substantia nigra is of mesencephalic origin. Okay, this part of the brain makes dopamine. Okay, and so degeneration of the substantia nigra is involved in Parkinson's disease. That's the core feature of Parkinson's disease. You can also easily identify the substantia nigra when we're doing brain dissections because of the darkly staining neuromelanin within the neurons. So it's easy to identify. Okay, the other part of the basal ganglia is actually a thalamic nucleus. Okay, remember, anything with the name thalamus in it is of diencephalic origin. So this is the subthalamic nucleus. Okay, and both of these are just good examples of movement disorders, right? Parkinson's disease, everyone knows that someone shakes as Parkinson's disease. Well, if you have a lesion in the subthalamic nucleus, you get something called hemiballismus. Ballistic sounds pretty dramatic. Hemi, one side of the body. And so these are usually strokes of the subthalamic nucleus when the patient presents with wild flinging movements on one side of the body, called hemiballismus. Okay, so in this section of the brain, let's just what we've talked about so far. We have a nucleus bulging into the lateral ventricle. So that is the caudate. Here we have the internal capsule. So lateral, this must be the putamen and the globus pallidus. Okay, and as we go deeper down, you can see, okay, here's a really dark staining area. So this is the substantia nigra. Okay, and we're not down to the brainstem yet, but for now, I'll just tell you this whole thing right here is the midbrain. So the substantia nigra is in the midbrain, and the subthalamic nucleus is kind of just above and lateral to the substantia nigra. And I don't know if you can appreciate, but when we do our lab, it almost always has the shape of a football. So kind of a football-shaped nucleus right here. This is the subthalamic nucleus. So again, if these neurons degenerate, substantia nigra, you get Parkinson's. If we have a stroke or something here in the subthalamic nucleus, your patient will have hemiballismus. Okay, and now maybe just better to identify these without the labeling. So caudate, internal capsule, putamen, globus pallidus, substantia nigra, and the subthalamic nucleus. All right, next, the limbic system, which what I will say is just very cursory here. Psychiatry will spend a lot of time talking about the limbic system. Okay, in a nutshell, what is the limbic system? Well, it's cortical and subcortical prosencephalic structures on the medial aspects of the hemispheres. So that's a lot. So let's remind you, what is prosencephalic? It's telencephalic structures, everything we've been talking about so far, and diencephalic structures. Okay, so we're going to point out parts of the limbic system that are here and also of diencephalic. So big picture, HOME can help you remember the basic function of the limbic system. Hypothalamus, for example, is the head ganglion of the autonomic nervous system. It's an important part of the limbic system. So it controls the pituitary. So there's an important neuroendocrine function. Controls the sympathetic and parasympathetic system. Okay, so that's all homeostatic. Olfaction is a function of the limbic system. Memory. We'll talk a lot about how our new memories, how does that get laid down in the brain? What happens in Alzheimer's when you have memory loss? Well, we're talking about the limbic system when we talk about that. And then psychiatry will tell you that the limbic system is involved basically in the unique way all of us respond emotionally to stimuli. So now for now, the main point is just to help you recognize and identify these structures. Some we've talked about already. I've pointed out the parahippocampal gyrus and the cingulate gyrus. Okay, so I'll remind you of those, and then we need to identify these other structures. So first, let's just look at the undersurface of the brain. So remember, we have our temporal lobe here. Here's the uncus, and here's the parahippocampal gyrus. Okay, so this is our first part of the limbic system, parahippocampal gyrus. Now, if we want to see these other areas, like from the last slide, the amygdala and the hippocampal formation, then we need to make a cut into the temporal lobe because those are deeper structures, okay? So in this drawing here, notice we just cut off the tip of the temporal lobe right here. And so the amygdala is kind of in this very anterior portion within the temporal lobe. Now notice, so you see the amygdala right here. As we go back through the temporal lobe, the hippocampus is very large. It extends all the way back here through the temporal lobe. Okay, so kind of looks like this. And actually, if I were to draw this, I'd put the amygdala more forward because it's more in the anterior portion. But the big picture here is, as you're cutting through the temporal lobe, you come to the amygdala first, and then all of your sections back from there are the hippocampus. Okay, so when we do our brain dissection, we're going to have half of a brain, and we're going to make a cut like this. And when you cut through the tip of the temporal lobe, which is right here, that's where you're going to look for the amygdala. It should be right there. And so the amygdala means almond. And just to appreciate, I'll point it out over here, it's a homogeneous neurons here in the temporal lobe that have about the shape of an almond, about the size of an almond. Okay, if you do one cut further back, you're going to go from the amygdala to the hippocampus. So let's do that. We make one cut further back, and the hippocampus is so distinctive in its appearance. Notice it's kind of a curly Q, a little bit like a cinnamon roll rolling up here. Okay, so this is the hippocampus. So both of those, amygdala, hippocampus, parahippocampal gyrus, these are all part of the limbic system. Okay, other important parts of the limbic system here are the cingulate gyrus, which we pointed out. And here is the hypothalamus. This whole area right here is the hypothalamus. Remember, head ganglion for the autonomic nervous system. Okay, cingulate gyrus we'll talk about a lot more. This is another area of the brain where if you have a lesion here, you can have impaired empathy. Okay. The cingulate gyrus is the best candidate when we use an expression like, I love you with all my heart. Of course, the heart doesn't really do that, right? The heart pumps blood around the body. So what if we want to be anatomically correct, we'd say, I love you with all my cingulate gyrus. That is probably the best candidate for that emotion we're trying to convey. Now, most people, when they say the hippocampus, they mean the hippocampal formation. So they're often used interchangeably. But when we say, what is the hippocampal formation? It's this whole area right here. When we looked at that little cinnamon roll curlicue structure, the tip of it is the dentate gyrus. Okay, the actual hippocampus is this CA1, 2, 3, and 4. And then there's a subiculum. Okay, so all of this is the hippocampal formation, and it is immediately adjacent to the parahippocampal gyrus. And we'll say a lot later on in the course about how this works as a memory, how you lay down new memories, and how the hippocampus is involved in that. Okay, so there is a pathway that is involved in laying down new memories. You're all using it right now, and it is called Papes circuit. Okay, so let's break this down. So the anterior portion of the temporal lobe, remember, is the amygdala. Okay, but Papes circuit really starts in the hippocampus, which is right here. All of these neurons, this is the whole hippocampus. So the pathway, a pathway for laying down new memories, goes from the hippocampus, and it travels all the way around here. This pink pathway here is called the fornix, and it travels all the way down to the mammillary bodies. Mammillary body is part of the hypothalamus. So this is kind of the first step from the hippocampus to the mammillary bodies. Okay, and then it goes up to a nucleus of the thalamus called the anterior nucleus of the thalamus. And then it goes up to the cingulate gyrus. And then it goes back to the hippocampus. Okay, so that is the Papes circuit. Hippocampus, and via the fornix to the mammillary bodies, to anterior nucleus of the thalamus, cingulate gyrus, and back down. So that loop is running continually. The entorhinal cortex right here is a part of the parahippocampal gyrus. Okay, I'm going to get rid of that. But this is kind of like the gateway of things that are getting in and out of the hippocampus. It all has to go through the entorhinal cortex. Okay, that slide is not important. But what is important here about Papes circuit, it's important for formation of short-term memory converting into long-term memory. The hippocampus can store memories for days, probably weeks, but ultimately to remember something long-term, it needs to get laid down in the hard drive, the frontal lobe areas of the brain that we'll talk about later. So Papes circuit is important for that. And so if we have a damage to the hippocampus, and the classic condition that does that is Alzheimer's dementia, which starts very early in the hippocampus of the brain. And so patients have especially impaired short-term memory. When I see someone with Alzheimer's, they can tell me with a lot of detail what happened 40, 50 years ago. But what'd you have for breakfast this morning? What'd you watch on TV last night? Those short-term memories are dramatically impaired because they really just have an inability to lay down new memories. Also, the hippocampus is really the GPS center in your brain. Okay, and actually years ago, a Norwegian scientist really made the discovery of this, or fleshed it out fully, that the sense of direction, good sense of direction, knowing where things are, you've been somewhere, you can find it again. The hippocampus is that part of your brain that's important for that. And that relates also to Alzheimer's dementia, because one of the earliest things we see in Alzheimer's is not just poor short-term memory, but spatial disorientation. And so getting lost while driving is something that I hear frequently is like the initial symptom of Alzheimer's. And as it progresses, patients get lost in their home. They can't find the bathroom. Okay, because you've lost the hippocampus, you really just don't have a sense of where anything is. Okay, and here is a medical student drew a Papes racing circuit. So it goes from the hippocampus via the fornix to mammillary bodies, to the anterior thalamic nucleus, to the cingulate gyrus, and back down. Okay, and I just couldn't find a better drawing than this. It's from an old textbook, but this is another C-shaped structure. So again, when you cut through like the fornix, you're going to see it in different places. But also, I just wanted you to appreciate here that the hippocampus, it's out in the temporal lobe. The mammillary bodies, the hypothalamus is very midline. So this C has to go from lateral and it moves forward to a very medial structure. So really the only thing I wanted to point out here is how it's going from lateral to medial down to the mammillary bodies. Okay, the amygdala, we talked about last year in the I think the lecture I recorded for your class on the autonomic nervous system. So remember, this is the fight or flight that gets activated, you know, when your heart races suddenly because something happens. The amygdala is like that fire alarm switch that goes off. And so a condition, which you'll learn about from our psychiatry colleagues here, is called Kluver-Bucy syndrome, where you have a lesion, usually has to involve both amygdaloid nuclei. And now something can happen and it just doesn't get triggered at all. So they have an impaired threat assessment. They don't activate the autonomic nervous system normally because of the destruction of the amygdala. So the amygdala, you know, to activate your autonomic nervous system, it has to talk to the hypothalamus, right? To kick in the sympathetics, the fight or flight. And that connection between the amygdala and the hypothalamus is called the stria terminalis. So keep the two pathways straight. The hippocampus talks to the hypothalamus via the fornix. That's for memory, Pape circuit. The amygdala for fight or flight talks to the hypothalamus through the stria terminalis. And I told you last year about inappropriate activation of the amygdala is what we see in PTSD, okay, where they just, even without the stimuli, the amygdala is activating, and how that is actually quite harmful. Okay, so here is the amygdala, and purple is the pathway here, the stria terminalis. And in the lab, this is a really small pathway, but I just want you to appreciate that the stria terminalis travels right along with the caudate nucleus. Okay, so when we're trying to find the stria terminalis, we'll want to look for the caudate because it's running right along with it. Okay, and it's going deep here down to the hypothalamus, but the hypothalamus is midline, so you can't see it on this pathway. It has to dive deep into the brain to get down to the hypothalamus. Okay, so another part of the limbic system is the nucleus accumbens. And again, psychiatry will tell you much more about this than I will, but where is the nucleus accumbens? It's right at here at the head of the caudate nucleus. And again, I know this is hard for you here, but when we do our brain dissection lab and we look at the caudate and the putamen, the nucleus accumbens is right here. Okay, the nucleus accumbens gets a lot of dopamine projections. It also gets projections, neural projections from the amygdala and the hippocampus. And this is a part of the brain that's definitely involved in reward and motivating systems, the positive things. When you listen to a piece of music that you just really, boy, there's a part, you look forward to this and you get a lot of reward listening to that part of the piece of music, that's the nucleus accumbens, that is, you know, that you're experiencing that enjoyment. Okay, so lots of positive things, rewards, positive things about the nucleus accumbens, but drug addiction, we'll talk about later. The nucleus accumbens is very important in that. And practically, I see this, I think, every week, it seems like, because I see a lot of patients with Parkinson's disease. And so in Parkinson's disease, we're giving medications that activate dopamine pathways. Remember, dopamine is very important. I mean, we use the expression, right? Where do you get your dopamine, right? Well, that's the nucleus accumbens. So when we give dopamine to treat Parkinson's disease, we can abnormally activate the nucleus accumbens. And so that can result in what's called an impulse control disorder, which is quite common. And so I always warn patients when I start them on these medications, you are not allowed to gamble on this medication. You would think that how often does that happen? Well, it happens quite a lot, actually. And I've had a number of patients, despite me warning them, that have gambled away tens of thousands of dollars, or an online addiction, poker, I have patients tell me about these games I've never heard of. Now I'm blocking on the name. It's something that a teenager would play, and the 75-year-old man is just addicted to his phone playing this game because he's on this medication for Parkinson's disease. So impulse control disorder is something we need to worry about in treatment when we use dopaminergic medications. Okay, so the cingulate gyrus, remember again, part of the limbic system. Remember this more anterior portion we mentioned is the energizing, getting the metal clutch out of gear. It's important for memory because remember Papes circuit travels through here. And I said that this is kind of the heart. You know, you'll have impaired empathy and emotions if we have something going on abnormally with the cingulate gyrus. Okay, and our last diencephalic structure, which we say very little about, is the olfactory system. Okay, so we have an olfactory bulb and tract I've already identified, and there are these little strial connections from there that go back to the uncus, and remember that is your primary olfactory cortex. I don't know how important this is, but in just a little bit, we're going to talk about the thalamus of the brain. And I will tell you that every bit of information, anything you can think of, vision, touch, sound, everything has to go through the thalamus on its way to the brain. The only exception is olfaction. Okay, it has a direct connection to the representing part of the brain without going through the thalamus. Okay, so whether the perfume industry maybe takes advantage of that, I don't know, but it bypasses the thalamus. Okay, so again, here's your olfactory bulb and tract, and going back to the uncus right here. And remember, if you make a cut right here, the amygdala is deep. It's right deep in this area, sort of adjacent to the uncus. And so if you've ever had the experience, like I went back to my high school where I graduated many decades ago, and it smelled exactly the same. And it brought back a lot of memories immediately, right? So the primary olfactory cortex is immediately adjacent to the amygdala, the hippocampus, and so you can kind of get this flood of memories from a smell that you haven't experienced in a long time. Now, before we go further, I want to make sure that we're all on the same page when we talk about orientation of the brain and making cuts through the brain or looking at an MRI or a CT scan. Okay, so when we make a cut this way through the brain, this is a horizontal section. Okay, when we make a cut like this through the brain, we start with the frontal lobe and work our way back. These are coronal sections. And typically, we're just going to make one midline cut that is a sagittal section. Okay, so for example, what kind of a cut is that? This is horizontal. Okay, a coronal cut would be like this. Okay, so we will have horizontal and coronal sections. The other thing that is important is orientation. The brain itself has a C shape. As it grows in development, it's a C-shaped structure. So when we look at the spinal cord, it's really easy. It's ventral or anterior, dorsal or posterior. Anything down further is caudal. Anything up further is rostral. Right? But because the brain develops as a C, what happens is this axis moves forward like this. Okay? And so, again, let's just talk about dorsal ventral. Dorsal ventral, dorsal ventral. It changes dorsal ventral. This is dorsal, this is ventral. This is dorsal, this is ventral. And so this is why when we talked about the lateral prefrontal cortex, this is the dorsal lateral prefrontal cortex. This is the ventral lateral prefrontal cortex. Okay, and so just keeping that terminology straight will help you. And also, like this becomes rostral, this becomes caudal. So we'll talk about something as being rostral to something that is down here, which is caudal. Okay, so we'll go through the rest of this fairly quickly. And again, we have a whole hour on the cerebellum. We have 3 hours on the brainstem. So this is a very, very big picture. Okay, but let's first, before we get to the brainstem, we need to talk about the other prosencephalic component here, which is the diencephalon. Okay, so how do we identify the diencephalon? Well, first of all, it's above the midbrain. Midbrain's usually pretty easy to identify, even though we haven't talked about it. It's right here. So the diencephalon is this whole area that sits right on top of the midbrain. So it is, again, if here is our rostral caudal axis, it is rostral to the midbrain, which is caudal, rostral, caudal. Okay, so when we're looking at associated cavities, remember that the diencephalon is associated with the third ventricle. That's our lecture on Thursday, but for now, I'll just tell you the third ventricle is always easy to identify. It's a big midline space right here. So anything on either side of the third ventricle has to be of diencephalic origin. Okay. The other important landmark is always the internal capsule, right? Here's the internal capsule. And so medial to the posterior limb of the internal capsule is right here, the thalamus. This whole thing is the thalamus. Okay, so the lateral border is the posterior limb, internal capsule. The medial border is the third ventricle. Okay, so some things we'll say very little about, but right back here, we have the pineal gland, which is part of the epithalamus. Pineal gland makes melatonin. So when we have our lecture on sleep, we'll talk about melatonin and describe how that works. Okay, and notice that the pineal gland sits right on top of the dorsum of the midbrain, okay, which we'll identify in just a few minutes. Okay, there is another part of the epithalamus called the habenular nuclei, but I don't think it's important, so we won't talk about that. But just the other thing I will tell you about the pineal gland, just really important when we're looking at head CTs, that this calcifies with age. And when you're looking at a CT, anything that calcifies looks bright. And so when you see this bright spot in the middle of the brain, that's actually pretty helpful. You know, you're looking through the pineal gland. Okay, now the thalamus itself is the largest diencephalic structure. It's huge. Okay, so again, medial is the third ventricle, lateral is the posterior limb. You will see frequently that there's a connection between the right and left thalamus. People always ask me about this when we do our brain labs. It's seen about 80%. Doesn't seem to be important at all. Okay, but anyway, just because you'll see it. So what does the thalamus do? In a nutshell, let's call it the executive secretary of the brain. This is the older terminology. Maybe should use something more modern, but basically any input that wants to access your cortex has to go through the thalamus. So right now, maybe you don't want to be distracted by someone mowing the lawn out there or by some tingling in your foot. And your thalamus is able to just kind of restrict everything down so that you can focus on the lecture. Okay, maybe at other times you want all of that input in, and the thalamus would allow your brain to be flooded with every bit of sensory input. So it's very important for sort of fine-tuning what has access to your brain. Okay, more about that later. Here's an MRI scan where we can see the internal capsule. Here's the putamen. Here's the caudate. And here is the thalamus. Okay, the hypothalamus is ventral to the thalamus. Okay, so here on a medial section, all of this is the thalamus. Okay, so if we move ventral, here is the hypothalamus. Okay, and so we have a whole lecture. Dr. Casasa gives you a lecture on the hypothalamus, but here is kind of a blow-up picture. So here's the thalamus back here, and then all of this is the hypothalamus. Okay, so the landmarks, one is right here is the mammillary bodies. Remember, that's part of Pape circuit. This is actually part of the hypothalamus, just a really large, distinctive nucleus. Okay, two other structures that are important landmarks that you don't know yet, and I'm sorry to overload, but We'll just label them for now and talk about them later. This is the optic chiasm. Okay, so this is kind of an anterior portion of the hypothalamus. And right here, there's a distinctive pathway. This is the anterior commissure. Remember the pathway that connects your temporal lobes, goes back and forth. That's the anterior commissure. So when we're looking kind of what are the landmarks around the hypothalamus? Well, you've got the thalamus back here. The floor of the hypothalamus is made up of the mammillary bodies, the optic chiasm, and the roof up here is the anterior commissure. And so you can be thankful for now. You don't need to know any of this. Okay, but this is our hour lecture on the hypothalamus, which just goes through all the individual hypothalamic nuclei, what they do, the clinical syndromes. And so I'm just show this for now and remind you that we'll come back later and explain in detail what is happening in the hypothalamus. Okay, but for now is a big picture. Remember, it's the head ganglion for the autonomic system. Talks to the pituitary, controls the pituitary, so it's a neuroendocrine function. And just a lot of what are called visceral regulatory areas, sleep-wake cycles, how your body temperature changes during the day versus sleep, feeding, and just the ability to recognize I am full or I'm thirsty. All of these kinds of things are a function of the hypothalamus. Okay, and then the other part of the diencephalon we've already talked about, the subthalamic nucleus. So it's part of the basal ganglia circuitry, okay, but it's also part of the diencephalon. So remember, you get hemibolismus with the lesion there. Okay, and now a quick overview of the brainstem. Brainstem is difficult. That's why we spend 3 hours on it, because there's so much going on, so many pathways going up and down, the cranial nerves, autonomic pathways, massive connections between the cerebellum and the brain. It's just a lot that is happening. So in an area of the brainstem called the reticular formation, which we can kind of think of as like the light switch for the brain. If you knock out the reticular formation, your patient's going to be in a coma. And so because there's so much happening here in the brainstem, you can have a small lesion, very small, and the patient is devastated. Okay, you take the same size of a lesion and put it up in the brain, and it may be completely asymptomatic. Okay, so small lesions in the brainstem can have big consequences. So let's first start about the midbrain. Okay, so remember the midbrain lies just below all of these diencephalic structures. So this is the midbrain. Okay, there are 3 parts of the midbrain. First, we have the cerebral peduncles, and these are lateral. It's a lateral pathway. This is a midline section of the brain. So if you were to put your finger in this space right here and kind of wrap around, you would feel this cerebral peduncle. And this pathway is really important. Remember, I told you, remember the cortical spinal tract, the cortical bulbar tract, and the internal capsule. The continuation of that pathway as it goes down travels through the cerebral peduncle. It's the same pathway, cortical spinal, cortical bulbar tract, but when it travels through the midbrain, we give it the name the cerebral peduncle. Okay, and the other important thing whenever we're talking about the brainstem is to recognize which cranial nerves are associated with which part of the brainstem. And with respect to the midbrain, cranial nerves 3 and 4, we will look for in and around the midbrain. Okay, now here's the pons. Okay, where's the midbrain? Well, it's deep in here. You can't actually see it. Pons is really large. The midbrain, to see the midbrain, what you need to do, which we can easily, is just take the temporal lobe and pull it apart a little bit. Okay, it's deep in here, and what we'll find is that the cerebral peduncles are right here. You just can only see it when you do this. You pull the uncus, the temporal lobe away, and there's a massive pathway. Okay, and that is the cerebral peduncle. So remember that what travels in the cerebral peduncle, those same 2 pathways we saw in the internal capsule, cortical spinal tract, cortical bulbar tract. Now, also, I said we look for cranial nerves in and around the midbrain. And so here is the 3rd nerve, not the best orientation. And here is the smaller fourth nerve that kind of wraps around the cerebral peduncle. Okay, and if we just try to dissect everything away to make it easier, here's the pons, okay, and here are the cerebral peduncles. One here, one here. It's huge, because just think of that cortical spinal tract. It has to move your arm and leg. A cortical bulbar tract has to talk with all of the cranial nerves. So it's a big pathway. And the third nerve is a huge cranial nerve because it does so much with regards to eye movement and the eyelid. And so the third nerve will look for just medial. Here it comes out in between the two cerebral peduncles. Okay, so this is a coronal section. So remember, it's like this. And what we've done is we've cut through the posterior limb of the internal capsule. I know this is hard now, but when we do our brain labs, I hope it'll make sense. Here's the posterior limb of the internal capsule coming down. Okay. And actually then the genu joins with this. And so this is the cortical spinal and cortical bulbar tract fibers. And when they travel down here, this is the cerebral peduncle right here. Same pathways, it just changes names. Now, how do you know this is the midbrain? Well, here's the substantia nigra, which is in the midbrain. So this whole area right here is the midbrain. Okay, so the lateral portion are the cerebral peduncles. Okay, so remember, what's in it? The continuing descending motor fibers in the posterior limb and genu. Now, the middle portion of the midbrain we call the tegmentum. Okay, and so this whole part of the midbrain right here is the tegmentum. Okay, and for now, here we've done a horizontal section through the midbrain. So these are the cerebral peduncles. Remember, they're lateral. Okay, so this whole area right here is the tegmentum. And so for now, I'll just tell you two structures that are in the tegmentum. First, the darkly staining structures. These are the substantia nigra. Okay, and then there's a round nucleus here called the red nucleus. Okay, so all of this is the tegmentum. So in a drawing here, you can see you've got the cerebral peduncles. Here are the third nerves coming out. And the tegmentum then consists of the substantia nigra and the red nucleus. This whole area is the tegmentum. Now, the back of the midbrain back here is called the tectum. And so if we were just to cut all of this off so that we can just look at this part of the midbrain, this is what we've done here. Okay, and so you notice there are these bumps here, a superior and an inferior bump. There's one on each side. And so this is the tectum of the midbrain, and we'll talk later on and explain exactly what that does. Notice there's a gland sitting right on top of that, and there it is. It's the pineal gland, right? So we cut all this off. What you're looking at here is the pineal gland here and over here. And then all of this is the tectum of the brainstem. Okay, the superior portion is called the superior colliculus. This has to do with vision. Again, we'll explain that later. The inferior portion down here of the tectum is the inferior colliculus, and this is an important auditory relay nucleus. And notice this is the only nerve that exits the dorsum of the brainstem. And here it is, the trochlear nerve. The only nerve that comes out back here. When I say dorsum, I mean it's coming out from back here. And so this has to wrap all the way around to talk to one single eye muscle. Okay, the pons consists of a portion called the basis pontis, which is really two pathways that are kind of mashed together. So the pons is just always huge. And I don't know if you can see, but these fibers are going this way. Okay. And so the pons has massive connections with the cerebellum. And this connection here is called the middle cerebellar peduncle. So that's one reason the pons has such a large shape to it. The other part of the basis pontis is that corticospinal tract. It has to make it all the way down to your spinal cord, right? And so it's traveling down like this. So when we say the basis pontis, we mean two pathways, the corticospinal tract, which is doing this, and the connection with the cerebellum here, the middle cerebellar peduncle. Okay, I think I've given you enough information. Let's stop there, and we'll finish up gross brain next time. Make sure to watch the videos here before the lab. Okay, I'll see you Wednesday.